third year now of doing this. It actually helped them as they've gone through into becoming residents and then
Right.
getting PhD.
I would add that there's these new grants that are a couple years old, 3 or 4 years old, called PCORI grants, Patient-Centered Outcome Research Initiative. And they really try to get the patient involved in their care. I think that's a growing trend in medicine. I think maybe I was a trendsetter in that a little bit, but I feel like the patient has to be their own quarterback. And they have to decide what treatment they want. They should keep their own records. It sort of annoys me that some doctor is saying, send me the records for this patient. Why don't you ask the patient for the records? The patient should be keeping the records, not me. So I think there's an emphasis now, and there's now this new emphasis on open access notes. We do that in my hospital also. The patient can go in, look at any note that was written, sort of prevents doctors from writing nasty things in notes because they know the patient's going to see it. So I think, what your school is doing is great, and I think that's the trend is really get the patients involved, even for sort of like a time-saving thing, If you're helping me out and you're making charts of your cortisol levels and graphs, that helps me out, plus it helps you out. And then you can take that to the next doctor you want. You have all these charts and graphs already made. Then trying to get lab, records from the doctor you saw a couple of years ago. If he doesn't want to send them to you. So I think just this whole, there's a TED Talk on this. I loved it on this. So I think just this whole trend of having the patients, more involved in their care is crucial. There is an endocrinologist in Virginia. She put in an article, pure article, worrying about people that use the internet for diagnosis. I think, everybody's using the internet for diagnosis. She wound up, I think she's probably eating her words down or something like that. Okay, more questions.
When you say mild Cushing, what do you mean by mild Cushing?
So I use that somewhat based on labs. So, your urine cortisol is maybe 1 to 2 times high, not 3 times or 5 times high. Patients with mild Cushing can have just as many symptoms, but their labs are not as high.
I know about this before. I think I'm still struggling with understanding. So episodic Cushing is random.
Right.
So it could be any time during 24 hours.
Well, I would say it's more like any time during the month or something like that. I would say in general, at least we know cortisol has a circadian rhythm. It's highest in the morning, lowest at night. We know cortisol has spikes throughout the day. So that's one of the reasons why it's harder to do it, because you don't know if you're sort of at the top of this, it sort of goes like this. On average, it's like higher up here and then lower down here. So part of it is, yes, you're measuring a one point in time with a salivary cortisol, for example. People ask me, so why do you just do salivary cortisols? You're measuring just 1 point in time, that 11 o'clock, 11:0001 time. A couple minutes later, it's going to be different because it's in little pulses all the time. But I would say, episodic is sort of random throughout the week or the month. They're periodics. They had, charts on it. It looks like it's sort of a sine wave. They measure this person's cortisol every day for like a couple of months, and they're like going up, and then it went down sort of even. My patients are sort of like this, throughout the day.
So there is still a difference in the day.
Yeah.
So, but you might not catch that. But okay, but over a week or a month, you'll see more of a high trend.
Yeah, I think you want to look at the overall values of this Gestalt idea. If you have somebody with all normal values, if you're doing a lot of testing and testing when people have like high symptoms, probably don't have Cushing. A patient has a lot of values, that's when you send the person to surgery. And I think, again, the ketoconazole is sort of like this intermediate. You don't feel that confident. They have some values, but not all others. You can put them on a trial of the ketoconazole.
I have a couple questions. You said
Maybe do one, and then we'll come back to it.
Okay. You said that the growth hormone can cause joint pain, and I have severe osteoarthritis, but my family also does as well.
Right.
Can too high a growth hormone injection cause severe osteoarthritis?
Yeah, I think first of all you want to keep it in the range, and you can have osteoarthritis that got worse with the higher dose of growth hormone, and you back down the dose and it gets better.
And my dose is normal.
Right, your level's normal.
Yeah.
Right, so then it's probably not related.
Okay.
Again, it sort of depends on where the normal it is. Some people, they're sort of high normal, you back down a little bit, it gets better.
Okay.
I think it's worth a trial. It's worth even a short trial.
Okay.
You could stop it for 3 days, and if your joint pain gets better, you can say, you're right, doc, I'm on too high of a dose, I'm going to cut down a little bit. If there's no change in 3 or 4 days, you just go back on the regular dose.
Okay.
In the back there? Any question?
Oh, I do have.
well, if you stay in bed until noon, you know, and you're not functioning during the time, could that have had an impact on the testing that my
Right.
endocrinologist did for me? You know, like
Yeah.
if I just woke up at like 3 p.m. and she had me take the dex at 11 p.m. Are those does my personal routine say anything?
Yeah, so that's a great question. So the answer is yes. So, we're doing our test, and what the laboratory has as a normal value is somebody that goes to bed at, like 11 or 12 and wakes up at 6 or 7. If somebody is phase shifted and they're going to bed at 6, it's hard to interpret their values. Somebody's, flying across the country, so sees me in Los Angeles, they're from Australia, so it's a little hard to interpret their values. So I would still recommend you try to normalize your circadian rhythm for your testing. But then, I still think you have to do your nighttime cortisol at nighttime of the clock, not your own nighttime, but of the clock nighttime. The 24-hour urine has that advantage of then, if you're phase shifting, you still do the 24 hours that cover the whole 24 hours. It might pick up something that might be easier to do, or you can try to train yourself for the testing and then do it then.
So with your patients that you do thyroid replacement on, if they're also replacing hydrocortisone, do you change how they're dosing in because the thyroid could increase the metabolism of their cortisol?
Yeah, so that's a good question also. So there's interaction between the hormones. The most important one, what's your name? Danielle says that what about thyroid and cortisol? So thyroid hormone breaks down cortisol. It stimulates a hormone called 11-beta-HSD, which causes it to break down. If you're hypothyroid, you don't break down much cortisol, and you can be on like a lower dose. Growth hormone does the same thing. So I have patients that, I think I'm doing them a service. They're on normal dose of hydrocortisone, doing well, and I say, boy, you're really undertreated on your thyroid. You're undertreated on your growth hormone. I'm going to give you growth hormone and thyroid. You can throw them into adrenal crisis. So therefore, sometimes you need to give them a little bit more hydrocortisone, or at least warn them to expect that, and maybe do your changes just a little bit one at a time. I know sometimes I would stagger the thyroid versus the growth hormone, but those things can cause you to break down more cortisol, and you may need a little bit more.
So would you suggest to say their morning dose when you first take your thyroid at the very same time? Would you maybe have a slightly
I don't think you need it at the same time. Just if somebody is they're on a stable dose of cortisol, their thyroid's low, I up their dose of the thyroid, they start feeling adrenal insufficient, I would say add an extra 2.5 milligrams of hydrocortisone to it probably. Back in the back.
I know you didn't talk about adrenal insufficiency today, but I have a son who was
Uh-huh.
last fall. He had insulin tolerance to reduce his
Uh-huh.
What would you recommend as far as deciding whether he should have feel any better?
Right. So that's a great question also. So I think the tests have to be done sort of with a clinical scenario in mind. My general experience is most endocrinologists give too much cortisol, put people on cortisol too often, and not enough growth hormone. And people can do fairly well, especially as we talked about here. Not everybody that has a stimulation test that's not 18 or 20 needs cortisol. Depends on their symptoms. They have no symptoms, signs, and symptoms of adrenal insufficiency. I might give them a med alert bracelet, give them take it if they have surgery or emergency. I might not give them day to day. But if they're having a lot of symptoms of adrenal insufficiency, that might be the key thing they need. So you sort of have to judge it based, I think, a lot on their signs and symptoms, not only on the stimulation test.
If you have growth hormone deficiency and thyroid disease, you can have adrenal insufficiency following that later.
Right. So the cortisol is the least likely hormone to go. So only maybe 10 to 20% or so will have cortisol deficiency that have growth hormone and thyroid. It depends on what happened to the surgery. If they had their whole pituitary taken out, they'll probably need it. But if they had, microadenoma and maybe a microadenoma removed, there's a good chance they don't need it. So I'm always trying to evaluate people. In general, hydrocortisone is a life-saving hormone. It's crucial. But a lot of people are put on it sort of routinely. They went for surgery. The surgeon put them on it just in case, and nobody took them off of it. And then if you take cortisol, you don't need it, you get Cushing's again, basically. So I'm always assessing whether people need it or not. Depends on the, sort of labs. I'd like them to withhold their cortisol for 24 hours, and then you do a morning cortisol level. Cosentropin test, I don't find that helpful because you have to be off cortisol for a long period of time for it to test it. But the morning cortisol, it's pretty good range. If the cortisol is 18, you can probably taper them off. If the cortisol is 3, you probably can't taper them off. And then your signs and symptoms. Some people still have adrenal insufficiency symptoms when they're on, say more reasonable dose. They might need a little more hydrocortisone. So I would say most things in endocrinology you test by labs. The adrenal cortisol, I think it's a lot by symptoms. You can do a 24-hour urine free cortisol and 17-hydroxysteroids. That sort of measures the integrated effect, especially the 17-hydroxysteroids, and see if the lab shows that you're on too much or too little. But most of the time it's on symptoms. Do you have another question over here?
I did.
You did.
What do you think is the long-term outlook for patients that have growth hormone deficiency? I feel like every year I'm getting more and more physical things wrong with me.
I don't think that's typical. I think most people on growth hormone do well.
Okay.
Very few of my patients want to stop it, and I think you can feel pretty good back to close to normal if all your other hormones are optimized. You might have something else going on. You might be fine-tuned. Maybe you need a touch higher growth hormone. But I think most people do pretty well on good replacement. Canadian lady?
I'm curious with regard to the fluids that I'm retaining. So I had ectopic Cushing syndrome, and during that period, I ended up with weeping edema. We then took the adrenals out, and 6 months later we found the lung tumor.
Oh.
But I'm still, and this is now 9 years on, having really bad problems with ankles, digits, expanding during the day.
Right. So are you on fludrocortisone?
Yes.
And you have a renin level?
Yes.
Okay, your renin's okay?
Yes.
Okay, so one thing would be the fludrocortisone, the mineralocorticoid. Too much can give you swelling, so the best thing to do is look at your renin level, and then your growth hormone could be too much. And then, people have edema. I think it's pretty common syndrome that may not be. And thyroid also. Is your thyroid optimized?
Thyroid is fine.
Okay, so, it might be something else, and, you have to, tease it. I can't really answer that question in a couple minutes, but it might be something you need optimizing, and you have something else going on. Some people I just give Lasix and it gets better. It's not a scientific to try to figure it out, but some people need just a little diuretic.
So
I find that carbs make people's edema worse also.
So where does vasopressin come in?
So vasopressin is the antidiuretic hormone. If you're low, you would have excess urination. You'd wake up a lot at night, and you might be a little dehydrated. So it doesn't sound like that's the problem.
No.
I have a question about talking to my endocrinologist about the 2-dose for the thyroid. I have no thyroid. I'm on growth hormone and insufficient. So still a candidate for twice a day on thyroid.
For the desiccated thyroid?
Yeah.
Yeah. Yeah. I
So
think you'd be a good candidate.
Talk to her about that.
Yeah.
We were just talking, we haven't been able to find information about what causes. I know high cortisol causes the buffalo hump, but why does it fluctuate? Why is that there? Why?
It's called mucopolysaccharides. They build up there. I don't know why they are. I think some people it's a good sign of high cortisol versus low cortisol when you're trying to monitor people for being at a high. Some people stays around a long time after the surgery. Some people have and don't have Cushing's, but it's a pretty good sign of Cushing's.
If someone's diagnosed hypothyroidism, would you recommend further hormone testing?
Essential or primary?
Well, I'm asking, I'm a patient, I'm type of sick, but we have a family history of a lot of hypothyroidism.
Right. So I would get a TPO antibody, and that would help you with figuring out what's primary or essential or both. And then if you have a TPO antibody, you can be tested for celiac disease, B12 deficiency. If you have pituitary, then you want to make sure all your hormones are correct.
So would you automatically recommend a cortisol test for someone newly diagnosed?
No. Signs and symptoms. The same thing with the celiac disease. Yes, adrenal insufficiency occurs more commonly in people with Hashimoto's, but still, only 1 out of 1,000 people with Hashimoto's would have Addison's disease. You want to think about it, relate some signs and symptoms. but you don't have to automatically test for it.
For patients that have been on for years, is it common to find side effects or to have side effects, or is that an uncommon?
I'd say I think all medicines have side effects, and everything needs to be monitored. So again, the main side effects of growth hormone would be swelling and joint pains. But I had a guy like his face got bigger on it. We stopped it; it got better. People get a lot of side effects on things. I would say growth hormone's probably at least more than average, if not, not that, a little more than average maybe. So always test your labs. Think about whether it's giving you a problem or not. Back there.
Hypothyroidism, but not adrenal.
Uh-huh.
When I have surgery, they give me dexamethasone with the surgery. Do I need to wean down from that?
Well, first of all, if you don't have adrenal insufficiency, I don't think you need dexamethasone.
Well,
I don't know. I mean, you had like a Cosentropic test, and you passed it.
Yeah.
Tell the guy he doesn't know what he's talking about. You passed the Cosentropic test, you don't need it. And I think overall, short term it's okay to take it, but the long term, I don't recommend it. But I recommend a very short dose for surgery, even the patients that truly are adrenal insufficient. I usually have them take 100 milligrams of IV hydrocortisone before the surgery, 50 milligrams after. The second day, double the dose. Third day, go back to normal. So you just really need, it's mostly the anesthesia seems to be that you need more cortisol if you're truly adrenally insufficient. I think the lady in the back had a question. Did we get you already? Or?
Yeah, I was going to ask if you would talk about term differentiations between PCOS and Cushing's. For instance, I am, even though you can't tell, I am the walking textbook picture that you were just talking about for Cushing, but because I have the PCOS diagnosis tied to me from, when I was age 15, I can't even get anybody to look otherwise, even though I have multiple saliva tests come back as high, even though my testosterone is off the chart, it doesn't matter, it's just all PCOS.
So, people can have both PCOS and Cushing's. And just because someone has PCOS, doesn't mean they shouldn't be tested for Cushing's. I had one patient that went to a prominent endocrinologist, and he said, no, we're going to send you to an OBGYN. If the OBGYN says, PCOS, we're not going to bother your Cushing's. I don't agree with that. I think you can have both, and I think they're sort of more common together. Part of it, you have the higher ACTH, raises your testosterone in Cushing's. I did publish a paper in Endocrinology and Diabetes, something, I don't remember the journal. It's a German journal, EACD, I think, looking at testosterone levels in patients with Cushing's and PCOS. So the idea is PCOS is a disease of high testosterone. Cushing's is a sort of a disease of lower testosterone. So in Cushing's, you have the other pathways of the adrenals make androgens. So usually your testosterone is sort of low. The cortisol also suppresses your LH and FSH. So in Cushing's, you usually have lower testosterone. So I used a cutoff of 31 of the testosterone. And if it was less than that, it was more consistent with Cushing's. Greater than that, it was more consistent with PCOS. And the actual testosterone level was better than the bioavailable testosterone. So I would, in your case, get a workup for Cushing's. Happy to come see me. And then get your PCOS treated. Yes. So usually in adrenal cancers, you can get high testosterone. Adrenal Cushing's, you're making cortisol. You usually have feedback, and your DHES is low. And presumably your testosterone is a little on the low side.
Secondary AI, pituitary radiation. Prednisone versus hydrocortisone. What do you think? I currently take Pred, and I'm fine with it unless I have to updose, and then its delay is too long. Can I take them both, or should I just?
Right. So, chocolate or vanilla ice cream, I guess a little bit, but I like hydrocortisone in general more. I use more of it, but I use all different combinations. Hydrocortisone has the advantage of having a shorter half-life. You can give more of it in the morning when people have higher cortisol, lower in the afternoon when people have lower cortisol. It sort of mimics the body's circadian rhythm. It's sort of whatever works for people also. If you're doing well in the prednisone, I think prednisone is good. I have a few people on a combination. Not sure, sort of they evolved that way and how we did it. I'm not sure exactly, but sometimes occasionally you do a combination. And I think occasionally you can stress dose with hydrocortisone and stay on your dose of prednisone if you have to stress dose.
Okay. Something like that was just.
Yeah.
Okay.
Yeah.
So the question for you. It started growth hormone, 0.2,
I filled the insulin pen. I was only on growth hormone for 2.5 weeks, trying to figure out what happened, but I had really bad tachycardia, ER, shortness of breath, palpitation, purple tummy pain, lost of 2.5 weeks. So the doctor that I'm seeing now, Dr. Yin, is retesting me to make sure I have it.
Okay.
Have you ever heard of that?
Yeah, so you have to make sure you don't have adrenal insufficiency.
Huh?
You have to make sure you don't have adrenal insufficiency. So it sounds like you have adrenal insufficiency. And
I was saying that they did my cortisol test and I have that barely over 18.
Yeah. You might need to check your cortisol binding globulins. That can give you higher cortisol. But your symptoms sound like adrenal insufficiency. And as we said, growth hormone and thyroid both cause you to break down cortisol more. So it sounds like, you started the growth hormone, you had this adrenal insufficiency type of symptom. So I would really reassess the cortisol axis on it.
The cortisol,
You can do a Cushing test.
where do you do that?
But it measures cortisol binding globulin also.
Cortisol binding.
Right. Are you on birth control pills or oral estrogens?
No.
Okay. So oral estrogens and birth control pills raise your cortisol binding globulin. So when you do the Cushing test, the insulin tolerance test, and look at cortisol levels, the cortisol could be falsely high because the binding protein is high. So that's what I would say. And then you might try a very low dose of the growth hormone, like 0.1 or 0.05, 0.1 every other
I
day.
think I want to
Look at the adrenals.
to make sure, because I don't want to do that again.
No, that doesn't sound too pleasant. Okay, we got 2 more minutes, so 2 more questions.
Related to hydration and dehydration, fluid retention, I try to manage myself a bit differently in the summer with,
Right.
heat and humidity.
Right.
It seems to be counterintuitive that when I think I'm dehydrated and felt craving, I'm also swollen. Does that make sense that my body's actually retaining fluids because I don't have enough?
It could be a little bit.
So what I need to do is take more Florinef or
Well, I would use your renin to judge you. In general, people need more Florinef in the summer than the winter.
I'd like to manage it a bit on my own. I take
Right.
a 0.05.
Yeah, I think people need more in the summer.
Okay.
The renin is probably would be very helpful.
I can't get that on a regular basis though,
Why not?
that test. Because my doctor won't order it.
You want to be online too? There's all these direct access labs. You can
Not
order.
in Canada, we can't.
Oh, you can't?
Without a doctor's order. Yeah.
Really? Okay, sorry.
So am I.
Yeah.
Should I take just the electrolytes? Is that like,
Electrolytes are very non-sensitive.
they're not, okay.
Right. And then you want to make sure all your other hormones are, optimized. Too much growth hormone, too little thyroid, too much cortisol even. Could
I think I'm on too little thyroid.
Yeah.
Yeah, I'm trying to tweak stuff. Thank you.
Maybe you should go to her medical school there.
I'm Toronto, unfortunately.
Okay. I think this lady in the back, then we'll get to you. And we'll close.
Just wondering, once your adrenal glands are then they become a tumor, like people that have scans, other scans can't find a tumor, adrenal glands are removed, and then tumors.
This is a pituitary question or adrenal question?
Adrenal, but ectopic, I'm saying once the adrenal glands are removed, then they find it.
Well, so top is two different things. So adrenal is usually pretty easy to find. You sort of know where you're looking.
I'm saying for ectopic.
Right, ectopics are hard to find. Could be anywhere in the body. It's usually a tiny tumor made underneath the pH, so it's a little like a needle that ate that thing. Most of them are in the lung, some of them are in the thymus, some in the pancreas. You said, she said they found her ectopic in her lung. That's common, but it's hard to find. Sometimes like tree pad scans are helpful. Multiple MRI, CTs are good. Sort of, it's just hard to find.
So then once the adrenal glands are removed, then they're easier to find?
No, then if the adrenal glands are removed, then you're in no rush because the problem with ectopics is high cortisol. Think of adrenals as high cortisol. You still want to find them because it could be a tumor or some malignancy, but it's not a rush. Usually people with ectopic are very symptomatic, as you probably were, and you take out the adrenals. Last question. Still here.
What's your take on the hyperplasia? First was like a 3 millimeter, and when it went into the surgery, it just
Yeah. So hyperplasia is hard. I think the people with hyperplasia do worse than the people that don't have it. It sort of means that, when you have a tumor, it's clearly demarcated, has like a wall around it, I find that this is for Cushing.
Yeah.
Yeah. So I find that for Cushing, a lot of times it's like an octopus with a bunch of arms, and you could get out like some of the arms, and then all of this I think comes back. But you can also have like some areas that are demarcated, some are not. So you have some little tail hyperplasia, and those are very hard to get out of. You have to like, scoop out that tail. And then some of it might be just like too early for a tumor to form. But in general, most of my patients, unfortunately, don't get cured with they have hyperplasia. Some people do. Probably you need a wider surgery. Yeah. Okay, thank you everybody. Again, I'll post this on my website and I'll get your back. And see you everybody.